So shall we go on to our next speaker, Dr. Sujata Guha, and she's going to be talking on packing a punch in paralytic. So on to you, Dr. Sujata.
Am I audible?
Yes, and we can see your screen.
Okay. So good evening, everybody, and I thank Dr. Chitra and the ARC for inviting me to this unique symposium. I shall be talking on surgeries for paralytic strabismus. And a brief epidemiology. The sixth nerve palsy is the commonest palsy. Most cases do have spontaneous resolution, with only a few, about 18%, going on to surgery. The surgery is usually done after 6 months of acute onset, when the deviation is stable. In the interim period, we closely follow up the patients at 6 weekly interval to see if there is any spontaneous regression. Before I delve into the surgery per se, we need to do a few assessments to help us plan the surgery. And let us see them one by one. So the main indication for surgery for paralytic strabismus is the presence of diplopia in the practical fixing gaze, which is mainly the primary gaze and the down gaze. And the second indication will be inability to maintain single vision without an abnormal head posture. So we need to see the position as well as the area of the binocular single vision field. So here you see a small binocular single vision field preoperatively, which is in the superior part of fixation. Post-operatively, we have expanded the binocular single vision field and we have brought it to the practical fixing primary position. We also need to measure primary and secondary deviation with either eye fixing. In paralytic strabismus, usually the secondary deviation is more than the primary. We measure in all positions of gaze and tilts. And here you can see a right hypertropia increasing in left gaze and a right tilt, suggestive of a right superior oblique paresis. In a paralytic strabismus, we need to do both the ductions and versions, and often versions will actually give us a comparison between the two yoke muscles. Sometimes when you have a very small paresis, the innervational force can mask a small paresis. But if you see that there is an overaction of the yoke, you can actually diagnose the small paresis. So we need to do both ductions and versions. Aberrant regeneration is again something we look for in a paralytic strabismus, especially in third nerve palsy. Here you can see the LPS aberrantly connected to the medial rectus and LPS aberrantly connected to the inferior rectus. And this can be used to improve the ptosis during surgery. And I'm sure Dr. Sharma will be discussing this. Now, forced duction test is something which we need to do for all patients. If there is a duction deficit, we do the forced duction test. And if on forced duction test, we find it to be tight, or we call it positive, then the possibilities could be it is a restrictive strabismus or there is a contracture of the antagonist muscle. If it is so, we go on to the FGT to differentiate. If there is a duction limitation and the forced duction test is negative, it is definitely a paralytic strabismus. Now we move on to the forced generation. If there is a normal tug on forced generation test, then it is probably a restrictive strabismus. If the forced generation test gives a negative tug, it is a paralytic strabismus. And if it's a weak tug, it is a paretic muscle which has got some juice left. So while doing the forced duction test, we need to be careful so that we don't damage the conjunctiva. GUYTO'Ns exaggerated test, it's a forced duction test for the obliques. And if we find a laxity on the GUYTO'Ns test, then it makes sense to tuck the superior oblique. If there is mild laxity or no laxity, then we avoid tucking the superior oblique because we run the risk of developing an acquired Brown's. Now, SACCADES, We compare the saccades between the two eyes. In a paralytic strabismus, the saccades are floating and the velocity on that side is reduced. In a restrictive strabismus, there are brisk saccades. It starts briskly, but the extent is limited, like something like a leash. We also need to do some subjective tests like the diplopia testing to see which is the magnitude of the diplopia in which gaze. We do the Hess chart to see the overacting and the underacting muscle, and Hess chart can also be done to see the progress of the disease. A double Maddox rod can be used to assess excyclotorsion, and most cases of paralytic strabismus do need imaging. Now coming to the surgery per se, depending on the results of our force reduction test, if it is tight, that means there is a restriction on the antagonist and we recess the antagonist, or we can do infinite recession like Dr. Rohit mentioned and periosteally fixate the antagonist, or we can use Botox. If the force reduction test is free, we do the force generation test. If there, and we see the saccades. If there is force generation, that means you still have some action left on the muscle, and then you can consider strengthening that muscle either by plication or by resection. Plication is preferred over resection because, again, the chances of anterior segment ischemia is less with plication. Now, if the force generation is completely absent, that means there is complete paralysis of the muscle, then we think of transposition. What is transposition? We move two muscles which is opposite to the field of the paralytic, which is not in the field of paralytic muscle, and we transpose them towards the field to make them act in the direction of the paralysis. So what are the different types of transposition? There is a full tendon width transposition where we bring the full muscle to and place it near the paralytic muscle. Here we run the risk of anterior segment ischemia, especially if we weaken the antagonist muscle. So the other transpositions are the partial tendons transposition or the Hammersheim's transposition, and the modification of this would be a small resection to further enhance the effect of this transposition. Another type of transposition is the Jensen's transposition, wherein we split the muscles, both the muscle to be transposed and the paralyzed muscle, and we join them together. The modification would be a vessel sparing Jensen's, wherein the risk of anterior segment ischemia is a little reduced. The newer type of transpositions are the Nishidas. In Nishidas, we really don't need to cut the muscle. We can split the muscle, and with a permanent suture, we can bring the muscle towards the direction of the paralyzed muscle and change the vector force of this muscle. A modification of Nishidas is, instead of splitting the muscle and then putting a suture, we can directly, without splitting, put a suture and bring that suture close to the insertion of the paralyzed muscle. Another modification is VRT and SRT. VRT is when both the vertical rectus is transposed, and SRT is when the superior rectus is transposed. You have heard Dr. Rohit speak. It is specially done for lateral rectus paresis and DUCTION'S when the vertical superior rectus is transposed to the lateral to the just superior to the lateral rectus. And augmentation of this transposition could be a Foster's suture, which is placed in the sclera around 8 millimeters posterior to the insertion of the lateral rectus. And the other modification could be an adjustable transposition, which again, I think Dr. Sharma will be speaking. So now coming to the specific muscles. I want to transpose all that we learned in the previous slides to the specific muscle. If the deviation in a fourth
1 minute remaining, ma'am.
Less than 15, and we have a significant inferior oblique overaction, we weaken the inferior oblique, and this is the commonest presentation. If there is no significant inferior oblique, and there is a tight ipsilateral superior rectus, we recess the superior rectus. And then if there is no tight superior rectus, we do a exaggerated force duction test, and we find the superior oblique lax, we do tucking. If not lax, we do now the contralateral inferior rectus. If the deviation is more than 15 prisms, we weaken the inferior oblique, as well as we do a superior recession or a tuck or a contralateral IR, depending on the tests. If there is more than 20 prisms of degrees of excyclotorsion, we do Harada Ito, where we transpose the anterior 1/3 to anterolaterally for correction of the excyclotorsion. This is a case of a right superior oblique paresis with a 25 prism right hyper, where we did a inferior oblique recession because the inferior oblique was overacting, and a left inferior rectus recession because the superior oblique was not lax and the superior rectus was not tight. Again, sixth nerve, we have the same principles. Here we have a 45 prisms of left esotropia in this patient of a left lateral rectus paresis with a tight FDT on the medial rectus and fairly weak saccades. He underwent a left medial rectus recession and a Nishida's transposition, which I talked about, and postoperatively he did well. This is my last case. We have a young girl with a face tilt, and you see there is a significant right hyper and the deficient the deficient duction, especially in abduction. So the depression was deficient in abduction, and we found that the inferior rectus muscle was absent. So we did inverse naps, that is, we transposed the lateral and medial to the inferior rectus region, and we Botox the superior rectus, and the post-operative results were really good. So to conclude, wait for 6 months before planning any surgical intervention. The primary aim is to shift the binocular visual field to the center. We should counsel these patients and set realistic goals. We can never have a full duction in all positions, and we can never have single vision in all positions of gaze, and choose the best option depending on the amount of deviation, the forced duction, and the forced generation test. Thank you.
Thank you so much, Dr. Sujata Guha. That was a very amazingly good talk. Dr. Kavita, could you take some questions?
Yes, ma'am. So, like for all strabismologists, managing paralytic strabismus is probably the most challenging. So, SG ma'am, what in your experience, which of the 3 nerves you find extremely difficult?
Third, without any doubt. I think because in the third nerve, we have deficient, all 3 nerves, the medial, the superior and the inferior, which are actually underacting or not acting at all. So we just have the lateral rectus and the superior oblique to play with. That is why the third nerve is a little difficult. I did not go into the third nerve because Dr. Pradeep Sharma has a full talk on third nerve. So, yeah. And the 6th is the easiest to manage. And the 4th, actually 4th. The 4th. Yeah. 4th is the easiest to manage. Mostly they have inferior oblique overaction and you just recess them.
Yeah, and they usually manage with a little head posture.
Yeah.
So, Dr. Muralidhar, I'm seeing now after long time. So, what about Nishida? Can Nishida be overcorrected, sir? Like Murali, any experience of Nishida being overcorrected? Like sometimes Foster's modificated VRT tends to have an overcorrection very rarely. So similarly, can Nishida ever get overcorrected? You can have an XT?
Yes, Dr. Kavita, actually we recently reported a case in Indian Journal of Ophthalmology where we did a Nishida's procedure along with medial rectus recession for long-standing 6th nerve palsy in a young patient. So the patient developed an exotropia of around 25 prism diopters with adduction restriction. The FDT was only mildly positive for adduction, and medial rectus was recessed to around 5 mm. So on exploration, we noted that medial rectus is where we want it to be. and we cut one of the foster sutures, one of the transposition sutures for the inferior rectus. So post-operatively, patient was orthophoric in primary position and had an expanded diplopia free field, and did not develop any vertical strabismus. So this is reported actually. So both for transposition procedures as well as for Nishida's procedure, that if you cut the transposition suture in case of Nishida or posterior fixation suture in case of transposition, you may be able to reverse an overcorrection.
So this point I just wanted to come out in discussion, because it's not always that the overcorrections do occur even if there is a complete sixth nerve palsy, even in surgeries like Nishida's procedures.
There is this question.
Very important point I wanted. Yes, ma'am.
There is one question from the attendees, Dr. Anuradha from Kolkata. In case of aberrant regeneration associated with third nerve palsy, should we operate the other eye? And titration for large angles of exotropia with hypotropia, she's asking.
Ma'am, maybe we should, after Sir's talk, maybe we could answer her question if
yes.
we might cover this.
Yes, true.